Dr. Anna Down. I'm a GP from West Ealing in London. And between 2012 and May 2024, I was GP lead for a care home service in Ealing, which was a single GP list for all of the care homes in Ealing. I've spent the last 12 years of my life deeply embroiled in advanced care planning and looking after residents in care homes, having conversations with patients, relatives and staff. I'm also lead for the Borough for Frailty, including end of life for Ealing, and at the moment I'm also working as a gypsy in palliative care. At the RCGP conference in October 2023, we were awarded the winner for the Daffodil Standards Award for advanced care planning in care homes for older people, and I was also highly commended for my own GP input. So the real principle underlying this is that actually delivering end-of-life care in care homes can be really rewarding. It's often straightforward once you start to have the conversations, but it can be really tricky. And I think the really important thing is that one bad or difficult experience within any home will change their perceptions and actions for a very long time. We only have one chance to get this right for each patient, and that needs to be every time. Advanced care planning needs to be ongoing conversations, it needs to be continuous, and that's quite hard, I recognise, from a GP and system perspective. But homes that have a bad experience will be nervous and have issues for a long time to come. So it's from a patient perspective, and it's definitely worth it for an individual, but for a home, it's worth it as well. The Daffodil standards have been developed to improve the experience for people affected by serious illness, end-of-life care and bereavement. Throughout these slides, there are little symbols and numbers. This highlights which of the standards are encompassed in each of the areas I'm talking about. And actually, care homes are involved in this every day at all levels of care. It's not just nursing homes, it's residential and learning disability and mental health homes as well. GP practice teams play a really vital role in delivering high quality end-of-life care and support to patients and their families everywhere, but particularly on the interface between care homes and healthcare. I've done quite a bit of work and talked about using data and learning from experience and feedback as a constant quality improvement project. Every single time there's something to learn from every patient and every home experience. But just a little bit more background about me and the service we were running. Up until May 2024, I was clinical lead for a service covering 38 care homes across Ealing. We started in 2011-2012 with 1 and then 2 care homes, and then we won a contract to look after all of them. For the last 4 years, this was approximately 1,200 residents at any one time across 38 different sites. The smallest was 2 beds, and the biggest was 165, and a variety of different needs and inputs across all this. It was really a GP-led multidisciplinary service. We did manage to increase the skill mix over the years and move to having other ACPs working with us and a lot of pharmacy input, from pharmacy technicians up to and including prescribing pharmacists, which was also very helpful. It was GP-centric and in part GP delivered, but actually really an MDT that made this service work. And the diagram at the bottom of this slide sums up how we view the care home GP interaction. So you can read it from left to right. There are patient processes, there are patient issues, acute, often on the day, patient issues, just as you see in any GP surgery on any day. Acute or chronic illnesses, new clinical needs, medication, carers' needs. You're all familiar with all of that. And at the bottom, the GP process, which is what everybody's used to doing, responding to patient needs and planning. But you can also read up and down in each of these columns as well to see where different MDT members might be and might interact. And the really key thing here is that the care home process sits in between the two. We all know how to deal with patients and we all know what we want to do as GPs, but actually the care homes in the middle can really influence what happens with any particular patient. They have their own regulatory environment, which means that sometimes you have to do things slightly differently to make sure they're able to implement what you want them to do. And really, I think that understanding that with care home residents, and I'm sure you all do appreciate that, it's this layer and these interactions that are really important. So navigating that information flow and needing to speak the sort of language of care home and be able to translate across it is really important. So, as I say, we drew this little schematic of an MDT with regular care home visits. That's what the whole service was based around, with regular visits and caseloads. so that the home knew the name GP for each home, and each GP knew their patient load really well. Joint working across the system to get holistic review was also increasingly important, and the more homes we looked after, the more important this became. This slide and the following slide shows some of the data we collected and analysed on an ongoing basis. Understanding usual patterns and looking for anomalies helped us target deeper investigations. For a list of about 1,200 patients, we have an average mortality rate of about 350 residents per year, and that actually didn't change very much from year to year, apart from in the early stages of COVID, and that's a whole other presentation. So it was about 350 deaths a year, and the first chart shows the deaths by month in 2013 to 2015, but there are similar ones up to 2024. We looked really closely at when they were and where they were, and particularly when we had anomalies pop up, we'd look and see if we could work out why that happened and if there was something we needed to address or consider. So in the first chart on slide 6, you can see the place of death for residents in 2015, and in the second chart on slide 6, you can see it in 2023. In May 2015, we noticed for reasons we didn't really understand, we'd seen a change to deaths being 50-50 at home and in hospital, whereas previously we'd managed to keep the majority of residents in care homes in their place of residence for their end-of-life care, where that was their wish. And one of the things we worked out, looking back at slide 5 and the graph on the right, is that what actually appeared to be important at that point was the provision of anticipatory medications into a care home, but it needed looking at further. So our pharmacist did a follow-up piece of work and found that the usage wasn't the relevant thing here. What we learned was happening was actually the provision of anticipatory medications was us making really clear signals to the home that we believe this person was now dying and that everything was in place and that it could be managed at home. And then this was about the communication from us to the home, to staff and relatives. And there were some care homes who felt that was very difficult. We had some that we had to do a lot of work with to make them comfortable to manage end of life at home. And these are the ones that sit at the left-hand side of the graph, percentages who died at home. Once we realised some of the barriers and how different homes perceived them, we could start to work more with some managers and staff, and we managed to change practices by improving confidence mainly. But it took a very long time to do that. Again, what this really brought out was actually it was about the team working and support and the communications with the homes. This was us being part of the team. In any particular instance, they say whether they use the medications or not was completely irrelevant, and the scatter chart for usage was completely non-linear. As you can see from the following charts, we carried on looking at this, and in 2023 we were still running at above the local average for deaths at home, but also pretty consistently managing to make sure that the majority of residents were able to stay at home if they wanted to. And that, of course, is another key point. It really depends on what the resident wants and what is appropriate. So we were often looking at things systematically and picking up trends. It's actually all about the individual, and we were working really closely with secondary care and all of the other MDT members on individual cases. And so we just pulled up a couple of case studies a couple of years ago now between us and the local hospital. With the geriatricians at Ealing, we compared information that we were getting from advanced care planning, from discharge summaries, and how that mattered to us and patients. So the first case study was drawn up by the GP practice. This was an 85-year-old man who was admitted to a residential care home, needing a little bit of help with his activities of daily living, but he'd been there several years before we got to know him. The care home moved under our care, and at this time he had Parkinson's, he had dementia, and he was just increasingly frail. But he'd been pretty stable, as the residential patients often are, for quite a long time. And what we found that he's had a lot of care planning for chronic disease management individually, but not really an advanced care plan, as it had been difficult to contact his next of kin. Here I emphasise advanced care plan. It doesn't have a D on the end, it's not advanced, it's not intrinsically harder. It is difficult conversations, but it's not harder, it's just in advance of things happening. That's really important. We wanted to contact his next of kin to say, well, what if? What do we think he would want next? And in the meantime, he'd had several admissions where he'd been treated for urine infections, chest infections, had short stays, and actually come back to the home sort of at a similar baseline. But then the home started to get to the point of wanting to send him in for he's not eating and drinking, just in case he's dehydrated. And we discussed in the MDT about the prognosis of this and the reducing impact of each admission for him, and that his dementia was worsening. We agreed that we thought this was probably coming towards the end of his life. We weren't sure how long, as with a lot of frail patients, it's difficult to know. However, we did manage to contact his next of kin, who was a niece, who understood he was more frail. This was, I think, probably 2022. She'd not seen him very much over the COVID lockdown periods, but she had seen him decline. She didn't want CPR for him. She just didn't feel that that would be appropriate. And after we'd had a chat with her, she felt that she didn't really want him to go to hospital anymore either. She'd taken him out to the park and she managed to have a little bit of a chat with him. She said, I know he doesn't understand all of it, but he really didn't want to go back to hospital. So at this time, we created an electronic end-of-life care plan to reflect this. We didn't refer to community palliative care because he didn't really have any specialist needs. He wasn't acutely dying, but even if he had been, I don't think he had any specialist needs that couldn't be met with district nurse and GP input. But that is obviously dependent on the patient. And then the niece again contacted us with that, with a quote at the top. Because we facilitated the conversation, she felt able to share this, and I thought this was very powerful. He chose a care home when he had capacity. He looked around it and he moved into that with the intention it was his home. And that's where he was going to be until he died. And I know one or two really good care homes who have that conversation with relatives quite early into their time there and say, you know, this probably is going to be their last home. And I think that helps them to set the scene. He continued to deteriorate. He got another chest infection and he didn't really respond to oral antibiotics we'd given him in the home. And we knew he didn't really want escalation to hospital, so this was probably an end-of-life event and he was actively dying. He was seen by the GP as well as the AMP looking after the home. We made sure that anticipatory medicines were on site and a district nurse referral made for administration because it was a care home and they didn't have nurses on site to give the medications. We made sure they'd got the right MAR chart and authorisation sheet completed and discussed it all with the care home staff, discussed it with his niece and made sure they were comfortable with what was happening. And he did die at home with his niece present. So they managed to correctly anticipate when he actually was going to die and she was with him. In this case, I think it all worked really well, but it was very easy to see how this could have gone wrong with different conversations or not having everything in place and that constant reassurance. And that can be quite difficult. The hospital also came with a case study for us, which sounds broadly similar as to what they would have seen in this man when he was going in. This was an 85-year-old lady who'd gone into hospital with fever, reduced output, so not passing urine, decreased oral intake, urine retention, was catheterised and given antibiotics for urinary tract infection, and was really quite delirious. She had a significant medical history, but notably 5 infections in the year preceding this particular admission. Turned out when they looked a little bit more closely that she'd recently been admitted to a care home within the last few months. And some of these admissions have been from there. She was completely dependent for all her activities of daily living and always transferred to a wheelchair. They did some advanced care planning in the hospital and liaised with the community via our GP community, MDT, and talked about what we thought she and the family wanted. And then the hospital liaised with the ward to ensure the hospital team knew of the next of kin wishes not for CPR for her, and actually not for any further hospital admissions, because that hadn't really come through in any of the previous plans. All they'd seen before is, and this is from the hospital perspective, is she's come in, we've treated her, she's gone out again, and then somebody's asked for her to come back in again. And so we managed to get the message through, and the hospital were able to hold a best interest meeting with her next of kin and the care home and formalise a more concrete advanced care plan for her, and that she was not going to come back into hospital. As a GP, we asked for that discussion to be written in detail on the discharge summary back to the GP, including detail on who they were with and what was actually said. not just a not for readmission comment, because that's really quite combative sometimes as a GP, where you're like, actually, I think this patient should come back into hospital and I'll decide that. This was much more collaborative. And again, the hospital updated the electronic end of life care record in this instance. Again, this case reinforced that communication was really important between all of the teams, but also with the care home, so that everybody knew that everybody had the same information. A lot of this, in fact, almost all of this work is about relationships, and it's about trust and about ensuring that the backup is there for every patient and every home. So along with these two case studies, we pulled together a little bit more thinking around what it was we thought we were doing around advanced care planning and care homes, things that worked and what the issues were. And I think the key points are here. The information gathering really needs to be done from the point of registration with the home. Within the care homes GP practice we created an admission pro forma that we got care homes to complete, that they sent over to us. So when they're completing their own care plans and putting in medical history and all of the paperwork they do in admission, we also said, well, can you fill in our paperwork when you register them? And that includes some of the social background, including sections on advanced care planning. We didn't necessarily expect them to answer that, but actually just normalising that part of the conversation of being quite upfront and saying, have you discussed this as soon as a patient arrived? It's the care home staff that are the people who are closest to relatives most often, particularly in that first instance. And delaying these conversations so that it all waited on the GP was actually counterproductive in some ways. We wanted to empower them to do it themselves. We said, you're having these conversations all the time. You know what the relatives are feeling. I'm happy for you to tell me what they're saying. And if I need to talk to relatives, then I'll talk to them. But actually, sometimes you've got all the information already there, and we just need to make sure we all know what it says. It's also an iterative process, so it's never one conversation. It's never one single review conversation. And particularly in the community, we were making sure that advanced care plans were reviewed, ideally a minimum of 6 monthly, but sometimes sooner if things were changing, or if we thought deterioration was happening, if we thought we needed to make other decisions. And again, trying to do that collaboratively with the home, with the relatives, with the MDT, to try and make sure that everybody had the information and it really is making it everybody's business. The care home staff often have all the contact with the relatives. They're often having ad hoc conversations if they feel empowered to do so. And some of that is about us listening to them and letting them have their conversations. But also some ad hoc teaching around the conversations and why we're making them, and to other healthcare professionals. One of the teams that I think are often really key to this is speech and language. If you've got speech and language review and they're starting to say, we think we should be risk feeding, that's a really key moment for advanced care planning. If we're risk feeding and that's for quality of life, do we know what we'd want to do when they inevitably get an infection? And sometimes that is that actually we would escalate to hospital for IV antibiotics if we thought they'd aspirated, and sometimes it's not. Identifying those sorts of moments and getting speech and language input, or knowing when they're having those conversations, is actually really, really useful. As I've said, I can't emphasize enough, communication is the key here across all settings. It's primary care, it's community care, but it's also secondary care and between social and primary care. This is where an electronic platform like the Universal Care Plan in London is really useful, because you can hopefully see recognition of active dying, and being very clear that that is what you think is happening is really key from a GP perspective, without having to have multiple people have similar conversations repeatedly. Making sure that all their necessary care and medication is accessible when it's required, and activating other services you need is important. So the district nurses or whoever else might be needed to administer medications. It's vital to keep families updated. And what we always found was really helpful was that we didn't allow individual DP's numbers to be given to relatives. What we would do is make it very easy for them to phone or email the care home service and have people accessible to say, we'll get someone to call you back later today, or we'll get somebody to see you, or arrange a meeting. So if they had any concerns, they didn't feel like it was being done without them. And the majority didn't use that access, but I think making that available just helped with that communication, to feel that it was in place. And my top tip is look out for the relative who's not visited for months, particularly if they're from overseas, because they might not have seen that deterioration. You might suddenly find that you believe that someone who's dying and everything's in place and everything has been done, but then somebody who's not seen them for a very long time or not really been involved appears and can throw everyone off track really quite quickly. So again, that communication and just trying to support that through can be really helpful. All this is basically just the practical implementation of those Daffodil standards. They're really helpful in supporting advanced care planning and end-of-life care, and there is a specific version for care home patients. There's lots in there, and it's about making sure your staff are competent so you know what your staff can do and empowering the care home staff. You can't be responsible for the care home staff, but you can empower them. Recognition of deterioration and dying and those ongoing personalised individual conversations and making sure they're documented, trying to make sure that when people deteriorate, it's according to the plans, but obviously plans change. And then supporting the carers and their residents and their relatives through this. A lot of carers, these are like their family, they've known them years, they might have looked after them for 20 years in some cases. And it's just like having a relative dying at home, particularly in smaller homes where it doesn't happen very often. And so allowing them to have some confidence in this and therefore doing some of the after death analysis and audit, not of everyone necessarily, but as a constant learning process, as I say, because it matters every time. Relationships are a huge part of this. Supporting care home staff to have these conversations, take it one step further at the appropriate moments and relay the information back to healthcare professionals. And as I said at the start, one bad experience will change perceptions for a very long time. That can even be beyond the staff who were there at the time remembering. There's a sort of institutional memory in some places that seems to say, you know, once or twice this happened and therefore we're not allowed to do this. We shouldn't do this. So it's really important to try and get it right each time, which is quite hard work. But what GPs are really good at is actually individualised complex patient care, and they manage both change and continuity. The final slides show more details on how to find the Daffodil standard, all the RCGP resources, and how to sign up and toolkits, etc. Thank you.